institutions that were keen on partnering with us. So without kind of further delay, it is my great pleasure and was sort of definitely on my very, very short list of N of one of who I wanted to hear speak at this series. So thank you, Dr. Goyali, for joining us today. Been a big, big fan of your work for a long time, and we're thrilled to have you. Dr. Goyali doesn't need any introduction, is a very prolific academician and kind of social media influencer as well, but most notably has done just tremendous work in the global oncology space and has been a fierce advocate for thinking about how we deliver care and kind of cost. I'll let him kind of come up with his terminology and use that, but really, cost conscientious and evidence-based guided care in low and middle income countries. He is a medical oncologist and associate professor in medical oncology and public health in the Division of Cancer Care and Epi at Queen's University in Kingston, Canada. His clinical expertise is across solid tumors, but does have a special focus on GI, GU, and breast. He is on the editorial and advisory board for countless medical journals, has co-authored over 200 peer review articles. My guess is that probably has gone up tenfold in the last week or so. I've seen a few of your publications come out recently. Has had academic interest in policy, evidence-based oncology, financial toxicity, clinical trial methods, supportive care, cancer care disparities in global health. Relevant to his talk today, he really introduced and coined the term cancer ground shot, as he has really been an advocate for investments and implementation of proven interventions for global cancer control. His interviews, studies have been, widely cited and noted across not only social media, but news outlets such as CNN, NPR, Washington Post, and notably is also an expert for the WHO Drug Advisory Panel and is a member of the Essential Medicines list for the WHO committee, as well as countless other kind of committee and national and international public policy committees. So without further ado, we'll turn it over to you. Thanks for joining us again today.
Thank you very much, Dr. Parikh, for that very kind introduction. It's my big pleasure to be sharing some of my thoughts with you all today. Can you see my slides?
Yes, you're good.
Okay. So yeah, thank you very much again. So the title of my talk today is about cancer ground set, which is the need for prioritization in global oncology.
Dr. Gowdy, can you shift to the presentation mode? Because we can see the next slide.
Okay. How does one do that?
Perfect. If you go to slideshow at the top, that should work. And then just from...
Yeah, it's good now.
It's good?
It went back.
It went back. Let's try.
Okay, maybe it's good now.
Perfect.
Okay. So I have no conflicts of interest to disclose, but I have a couple of disclaimers, which is that I might be criticizing a number of trials. And if you are involved in those trials in any way, don't take it personally. These are just representative examples, and I have nothing personal against these trials. Okay, so let's talk about a hypothetical patient that we might be seeing in our everyday clinic. I do GI. So let's talk about a certain patient who presented with symptoms of bloody diarrhea, did a colonoscopy, there is an infiltrating bleeding mass on the ascending colon, biopsy done, there is adenocarcinoma, imaging shows that there is no distant metastasis. This is our typical patient that we see every day in the clinic. So let's think about what will the outcomes of this patient depend on. And probably these are what we would come up with: the disease biology, whether the patient will receive surgery in time, the size of the tumor, lymph node involved or not, mutational markers, right-sided colon, left-sided colon. Did the patient get adjuvant chemo on time? and all these factors that we normally are trained to think about as a doctor, as a medical oncologist. But is it true? Will the outcome of this typical patient that we see every day in the clinic, does it depend only on these factors? Is that all? Unfortunately, the answer is no. The outcome will also depend on educational status of the patient, the wealth of the patient, the family status, social support, neighborhood, geography, indigenous status, language barriers, immigration status, mental health, other conditions, race, ethnicity, sexual orientation, gender identity. All these factors also, unfortunately, and it is proven. I have not cited evidence for each of these, but these are the factors that are proven to affect outcomes for a typical patient with cancer. But this is unfortunate because these are things that are not biology. These are not things that should be affecting the outcomes, but unfortunately they are. And it is now known that in biology, in fact, the zip code can be even more important than a genetic code. Where you live is more important than what the biology of the cancer is. So this is an unfortunate situation that we have landed ourselves in. And that proves that new discoveries are not the only things that matter. What matter is how our discoveries penetrate into the societies and how our scientific innovations reach patients that need those innovations. And there was an interesting article. This was a fantastic article that I had read, and I think it's not very well-known piece, but I strongly encourage you to read this. It talks about the break-even point in medical advances. And here, the authors argue that we spend billions of dollars in the development of new drugs and technology, but comparatively little in the fidelity of healthcare, that is improving systems to ensure the delivery of care to all patients in need. And what they show here is that there is a break-even point when discovery of new innovations will have less benefit than spreading those innovations to people in need. And that is when and that is where the concept of this cancer groundshot comes into play. We wrote about cancer groundshot back in 2018 in the Lancet Oncology. And this was when there was all this big hype about the cancer moonshot projects and how we are going to treat our way out of cancer through immunotherapy and precision medicine. And that all sounded very sexy, but the reality was that patients were dying in the world, not because they did not have access to immunotherapy, but because they did not have access to surgery, radiation, and paclitaxels. And in this paper, we wrote that we propose that we need a parallel cancer groundshot, not as a replacement to moonshot, but we need a parallel cancer groundshot to improve the lives of the patients today and in the next 2 decades. And, you know, we are so much seduced by this attraction of new development and new innovations and newer drugs that we forget that we have not been, like, all the drugs that we have discovered and we are happy about in the last decade, they have not reached even 15% of the patient population in the world that actually would benefit from those drugs. And on the other side of the tragedy is the fact that a majority of the new drugs that we have discovered, they are not actually even benefiting patients who have received those drugs. So there is 2 sides of this equation. One is that majority of our drugs are not good enough to begin with. And of those handful of drugs that are really good, we have not been able to give it to patients who need them. And in fact, if we look at how much overall survival our drugs are improving, the newer drugs, the latest data that we have shows that the drugs approved by the FDA improve overall survival by a median overall survival by an average of 2.9 months. It's just below 3 months. CADATH is what we have in Canada. About this is an agency that reimburses. This is a health technology assessment body, and the drugs that are funded through CADATH, they have an average overall survival gains of 3.7 months, and which is not nothing, but it's not a huge advancement that we should be proud of. And people can question that: is this because of lack of spending? If we spend more, do we improve outcomes? And there was a very interesting study published in JAMA Health Forum last year, which tried to look at that question. They looked at all the high-income countries. They looked at how much these high-income countries are spending in cancer care per patient and what the mortality rates are. And if you look at this, you see that US is an outlier. Of course, US spends the most per patient. which is almost $600 per patient, which amounts to $200 billion in total per year on cancer care. But if you look at the cancer mortality rates, US is just average. It's not doing better than the average. That means even after spending the most in the world per patient, the mortality rates are just average. And there are so many other countries that you see here, which are spending far less than what US is spending. Countries like, Iceland, is spending only $200 per patient, and the mortality rates are not too bad. So, just by spending more does not lead to improvement in outcomes. And of that $200 billion that US is spending, 10%, which is almost $21 billion is on prescription, is on cancer drugs alone. So the reason we are not improving these outcomes is not because we are not spending more, but probably we're spending a lot on drugs that are not actually improving outcomes. So why is that happening? Why are we spending so much on drugs that are not improving outcomes? And that is where the role of surrogate endpoints come into place, because we are approving and spending a lot on the drugs that are not tested to measure survival and quality of life outcomes that actually matter to patients, but they are being approved based on their effect on some arbitrary endpoints that may or may not reflect patient-centric benefit. Then the question is, why are we using these surrogate endpoints then? Why use it at all? There is some merit in using surrogate endpoints because it saves time and allows earlier analysis and publication. Which is a legitimate point. But sometimes people think that if we wait for overall survival, we would be waiting for 5-10 years. And that is not true. In fact, a study has shown that compared to using overall survival, if we use response rate, then we save an average of 19 months. And if we use PFS, progression-free survival, then we save an average of 11 months, almost a year, which is not nothing, but it's not like 5-10 years that people think it is if you wait for overall survival as opposed to PFS. And there are several examples, like, for example, Bolero trial. It was approved, everolimus was approved in breast cancer based on PFS in 2012. But if we had waited for 1.5 years, we would have overall survival data, and the overall survival was actually negative. So the surrogate endpoints, they make sense logically, but the problem is the surrogate endpoints, they do not correlate with the outcomes that matter. So these are shortcuts, but not all shortcuts, they work. So what makes a good surrogate endpoint? And this is FDA's language. The FDA says that clinical trials, they are needed to show that surrogate endpoints can be relied upon to predict or correlate with clinical benefit. And surrogate endpoints that have undergone this testing are called validated surrogate endpoints. And if the surrogate endpoint is validated, then the FDA would accept it as evidence of benefit. But if we look at the data, if we look at what percentage of these surrogate endpoints have been validated, I don't know, this graph looks a little off, but yeah, so the majority of the surrogate endpoints have very low correlation with overall survival. So they are not validated and are still being used. And that is where the heart of the debate is that these surrogate endpoints are not inherently good or bad. If they correlate with overall survival, then they should be acceptable. But the problem is in most of the settings, and this blue graph represents low level of correlation. In most of the settings, the surrogate endpoints have very low correlation with overall survival. And the other problem is that it is difficult for patients to make this concept understand because, and again, this is a fantastic study, again, done by colleagues at FDA, in which they asked 971 participants, and they showed a television advertisement, and that advertisement said that this drug improves PFS, and it did not say anything about OS. It just said that this drug improves PFS. But more than 90% of the patients, they thought that it improved survival just by hearing that it improves PFS. And then they showed another advertisement, the same drug, and this time they specifically mentioned that the data on survival was not known. It improves only PFS. Even after making that explicit disclosure, 40% of the patients, they continued to believe that the drug did improve survival. And so there is A, PFS does not correlate with OS in most cases, and B, patients assume that PFS means survival. And it is very hard for them to understand the difference even after explicitly mentioning that it does not improve survival. And I think a part of the problem is when we say PFS, progression-free survival, patients hear the last word in that phrase, survival, and so they think inherently that it does improve survival. So in fact, we wrote a paper saying we need a new name for PFS. We should not be calling it progression-free survival. And in this paper, we propose that we should be calling it progression-free interval so as to avoid confusion. Then the other question arises, okay, PFS does not correlate with OS, fine, but quality of life is also an important endpoint. So doesn't delaying progression lead to better quality of life of the patients, which is a very important question. And we tried to answer that question. Okay, does PFS correlate with quality of life then? And in this paper, we looked at that, but this is what we found. We studied 352 phase 3 randomized trials. The unfortunate thing is that half of them, they did not even include quality of life as an endpoint. And of those that did, a quarter, they did not report on pre-specified quality of life endpoint. And of those that did give this data, when we analyzed, we found that the correlation between PFS and improvement in quality of life was pretty weak. It was only 0.34, which is a very weak correlation. So yes, improving PFS does not necessarily lead to improved quality of life, which might sound counterintuitive, because if you delay progression, shouldn't the patient feel better? But I think the explanation lies in the fact that quality of life is not affected by disease progression alone. There is also toxicities that affect quality of life, so that balance is important. And B, it also depends on the way we define progression. That arbitrary threshold of 20% in the RECIST criteria, there is no reason why a patient should feel different when the cancer grows by 18% versus 20.5%. So, and therefore, improving PFS does not automatically lead to improving quality of life. And therefore, we insist that quality of life should be specifically measured as an endpoint in the trial and not just guessed based on improving PFS alone. In a more recent paper, we looked at several drugs that improved OS and had quality of life data, as well as PFS and had quality of life data. And something surprising that we found is that in no case that a drug that improved overall survival worsened quality of life. So if a drug improved OS, then it will either improve quality of life or at least keep quality of life stable. It does not worsen your quality of life. But when we looked at PFS, we found occasions of drugs that improved PFS, but in fact worsened quality of life. So we have some of these drugs in the market that improve PFS, does not improve overall survival, and in fact worsens quality of life. Then in that situation, we need to be asking ourselves, what are these drugs doing to our patients, and why are we spending on these drugs that does not improve survival and in fact worsens quality of life for our patients, based on simply because they are delaying progression in scans. So this was one of the most recent papers that we wrote, and it was understandably a little bit controversial because our title was PFS should not be used as a primary endpoint for registration of anti-cancer drugs. And we outlined several reasons for this. And again, when we are talking about registration of cancer drugs in US, there are different pathways, accelerated approval pathway and regular approval pathway. At least PFS should not be used for approval of drugs through the regular approval pathway. And when we are having all this discussion about surrogate endpoints, some people make a comment that, but maybe it matters to the patient. Maybe delaying progression matters to the patient. And the answer to that is it matters to the patient because we tell them that it matters. Otherwise, they would not know whether the cancer size has grown by 18% versus 21% and why that makes a difference. And B, actually, our group did study this, and this was recently published. We asked patients and we gave them different scenarios, and this is the result. 51% of the patients, a majority of the patients, they said they would decline a cancer drug regardless of PFS benefit, no matter how much PFS benefit it offered. But 17% would prefer a drug for no PFS benefit as well. So there are a spectrum of patients. 17% would take a drug for no PFS benefit. 26% would take it for some PFS benefit, range 3 to 9 months. But 51% would decline it regardless of the magnitude of PFS benefit if the drug does not improve OS. And of course, the surrogate endpoint is just one part of the trial design issue. There are several issues related to trial design, implementation, and analysis that can affect the result of the trial and the interpretation of the trial. And this is an open access paper that I encourage you to read, in which we highlight 10 different issues with trial design that can affect the interpretation of the trial. But this is just to say that the reason that we have spent so many dollars on our cancer drugs, but at the population level, it has not translated into improved outcomes for our population, is probably because we are spending a lot on drugs that actually do not improve outcomes. And there are, as I mentioned, there are multiple other issues beyond surrogate endpoints as well. And we have discussed about this in several papers. We have written about this, like crossover issues, post-protocol therapy, and so on. But just to give you one example of how we are chasing statistical significance rather than magnitude of benefit. This drug, margetuximab, was approved by the FDA for metastatic HER2-positive breast cancer back in 2018. And if you look at the magnitude of benefit here, the median PFS, you can see on the table, is 4.9 months versus 5.8 months. It's not even 1 month. And it's not even OS, it's PFS. A less than 1 month improvement in PFS led to full approval, not even accelerated approval, full approval of this drug by the FDA. So this is just an example of where things are. But the fact is, us getting to debate about these issues, about surrogate endpoints, about that previous drug, margetuximab, improving PFS by less than 1 month and still getting approved, this is a real privilege. Because if we look at LMICs, low and middle income countries in the world, the tragedy is they don't have access to even the best of the drugs that are out there. And also, in some of the LMICs, they are spending their limited resources, whatever they have, on these drugs that we are considering of low value, even in high-income countries. And the reality in low and middle-income countries is that we are not even able to offer interventions that actually work, interventions that cure lives, for example, surgery. This Lancet Commission back in 2015, it looked at the burden of cancer surgery, and it found that by 2030, 45 million cancer surgical procedures will be required in the world, of which 10 million will come from low and middle income countries. But less than 25% of the patients with cancer globally will be able to receive safe, affordable, or timely surgery. Less than 25%, not even a quarter. And some people argue that building surgical facilities in low and middle income countries, it's very expensive. But it's exactly the opposite. We can't afford not to build those because there is a huge financial cost to this in terms of the lives lost, the life years that are lost, up to $6.2 trillion by 2030. The same is, if you look at the global access to surgery, then the redder the country is, the higher the proportion of population without access to surgery. And you can see that most of the countries, especially the low and middle income countries, you see Southeast Asia, you see Africa, they are all red. That means we are doing such a poor job, even with providing interventions that actually work for the patients and actually save lives. The same is true for radiotherapy as well. The number of, this is access to radiology, the number of CT scans per million population. Very few countries in the world, they have more than 30 or even more than 15 CT scans per million inhabitants. Most of the countries in the world are doing without, there are some countries in the world that have no CT scan machines at all, the entire country. The situation with radiotherapy is similar. More than 50% of cancer patients who require radiotherapy, they come in LMICs, they lack access to treatment. If you look at low income countries alone and remove that middle income countries, the proportion is higher than 90%. More than 90% of the population who need radiotherapy in low-income countries, they do not have access to radiotherapy. There was this news article in BBC that caught my eye. It provocatively asked, do US dogs have better access to radiotherapy than Nigerian people? If you look at the data, there is one radiotherapy machine for every 1.28 million cats and dogs in the US, but one radiotherapy machine for 46.5 million people in Nigeria. And this is nothing against cats and dogs. We love them, but it's about the level of disparity that exists in the world. between low-income countries and high-income countries in terms of access to things that actually work. We are not talking about access to those low-value cancer drugs. These are access to things that will cure them. Palliative care. The situation is even more brutal. Several countries in the world, they don't have proper access to morphine. This graph is quite enlightening. It shows what percentage of morphine need is available in the country, and countries like US and Canada, they have more than 3,000%. That means we have such a huge availability of morphine than what we will ever need. But if you look at countries like, let's say, India, there is only 4%. If you look at Afghanistan, 0.2%. So there is such a huge disparity in just the availability of drugs like morphine that actually makes a meaningful difference in patients' quality of life, especially towards the end of life. And when this level of disparities exist in the world, I did not find much meaning in getting excited about cancer moonshot and how we are going to solve our global oncology problem with cancer moonshots and newer drugs. Newer drugs is not the reason why most of the patients in the world are suffering. And in fact, this cancer moonshot became so seductive that everyone wanted their own cancer moonshots. So many institutions in the world, they have their own cancer moonshots program. And in fact, Nature had to publish an article saying there is worry that cancer moonshots are multiplying. So, I thought, like, what we need is prioritization. What do we need first and second and third? So when you think in terms of priority list, prioritization is the most common sense approach to any problem. And I'll show you this slide here and look at the contrast. On one side, it talks about surviving cancer in a country with no radiotherapy machine in a low-income country. And on the other side, again, it comes from this comes from India, which is not a high-income country; it's a low-middle-income country. But they are talking about Watson for oncology and how this artificial intelligence is going to solve our problem of lack of medical oncologists in the country. So I don't think artificial intelligence is the solution to this global cancer disparity. And after this, I wrote this paper in Lancet Oncology asking, does global oncology need artificial intelligence? And my conclusion was that we need a natural common sense more than any artificial intelligence. Let's take the example of cervical cancer, for example. This is the cervical cancer mortality rate in the world. The redder the country is, the higher is the mortality. It's really unfortunate that any woman needs to die of cervical cancer in 2023, in this era. Nobody should die of cervical cancer. If we can talk about eliminating any cancer, that would be cervical cancer. In all other cancers, we can't talk about elimination. But for cervical cancer, we actually can. And because we have good understanding of the etiology, we have good vaccinations and screening. In fact, there are countries in the world that are on their track to eliminate cervical cancer, like countries like Australia and New Zealand. They are going to be the first countries in the world to eliminate this disease. But when you talk about cervical cancer in these big forums and meetings, people talk about access to pembrolizumab and bevacizumab. And that's completely besides the point. The first question we need to be asking is, why should there be patients with advanced cervical cancer who need these drugs in the first place? And ASCO allowed us an opportunity to talk about cancer grounds. 2 years ago, we had a session on cancer grounds at ASCO, and we published this chapter in ASCO educational book as well, which I encourage you to go through. But cancer grounds is basically about our prioritization. What should be our priority list, and how should we think about addressing this global cancer burden? And of course, I'm not discounting drugs. I'm a medical oncologist. I use drugs every day for my living. But we should also prioritize what are actually important drugs that we need to fight for versus what are drugs that are good to have or not even good to have and completely valueless. So when we are thinking about equitable access to cancer drugs, there are two problems to this. Why are our patients in the world not having access to cancer drugs? And there are two reasons. One is the availability, and the other is the affordability. And these are different things. Availability is the drug just is not available, irrespective of whether or not you can pay for it. You may be able to pay for it, but if the drug is simply not available or not approved, then that's one problem. The other is affordability. The drug is available and approved, but you just can't pay for it. And why would a drug not be available in a certain country or jurisdiction? There is delay due to regulatory sluggishness, and there are data to show that US approves cancer drugs far ahead of most of the countries in the world. And even if you compare with other high-income countries, for example, Europe, I think US approves cancer drugs almost a year before EMA does. And then there is the problem of production, manufacturing, or importing issues, especially for countries that don't have their own manufacturing capacity. They need to rely on suppliers from outside, and the suppliers are unreliable, and there are other problems, including budget capitation. Certain countries, they allocate a fixed number of budget to get cancer drugs every year, and if that budget is exceeded midway through the year, then they will have issues getting cancer drugs for the rest of the time. And then there is the issue of continuing with the issue of availability. We members of the WHO Essential Medicine List, we wanted to do a survey of oncologists in different parts of the world, low-income countries, high-income countries, and we asked them a couple of things. One is the classical desert island project. We told them, okay, you are going to a desert, and in your backpack you can carry only 20 drugs, cancer drugs. What are the drugs that you would carry? So in a sense, we wanted to get their idea about what were the most important 20 cancer drugs that they think is needed for the practice. And then we asked later on about the affordability of these drugs. So a couple of things to highlight here. You will be very surprised that there is a lot of overlap between the cancer drugs that LMIC oncologists and high-income country oncologists think is most important for the practice. And most of these drugs are actually classical old cytotoxic drugs. There are a few newer drugs or targeted drugs and immunotherapy here and there, but the majority is constituted by old classical drugs. And the striking difference between LMICs and high-income countries is these newer drugs like pembrolizumab or osimertinib, they show up in the high-income countries list, but they do not show up in low and middle-income countries list. And the other interesting thing to note here in this table is what percentage of the oncologists thought that this drug was available to them whenever they wanted to use it. And you can see in LMICs, even drugs like doxorubicin, cisplatin, cyclophosphamide, carboplatin, these old classical drugs, capecitabine, the availability is so low. It's not even 50%. Except for dexamethasone, none of these drugs have hit 50% mark, which is incredibly sad. And when you compare that to high-income countries, of course, we have access to pembrolizumab even 70% of the time, and most of the other drugs are like all of these drugs, they are more than 60% here. And let's talk about affordability. Affordability is the other part of the equation after availability. Okay, the drug is available, but is it affordable? And we did, I come from Nepal, so we did this survey among Nepalese cancer patients who had acute leukemia, and they were getting treated in a public hospital in Nepal. And we asked them, and we chose acute leukemia because the treatments were classical old drugs that we thought were cheap in the context of Nepal. And so we wanted to ask what percent of the patients face financial toxicity in receiving this treatment. And this is what we found. We defined financial toxicity as any one of the three parameters. One is if they had to ask money from charity, or they had to borrow loans subject to high interest rate from friends or relatives or whoever, or if they had to sell their property like house or land or livestock. And 73% of the patients, they faced all three of these, which we defined as extreme financial toxicity. So they had to sell their property, they had to borrow loans at a high interest rate, as well as ask money from charity. And remember, this is acute leukemia being treated with classical old drugs. These are what we thought would be the cheapest treatment in the context of Nepal. And even these patients have faced such huge amount of financial toxicity in the context of Nepal. So the drugs might be old and cheap, and the drugs might be available. Even then, patients are facing meaningful financial toxicity in getting treated with these drugs. In this paper, where we talked about financial toxicity and addressing the problem of financial toxicity, we discuss a 4-step solution to this problem. And the first step is to just acknowledge, because now things have changed. But I'll tell you that until 7 or 8 years ago, people did not even accept financial toxicity as a real thing. People thought this was a political made-up thing. When in the past 5 to 7 years, there have been several body of literature which has shown that financial toxicity is clearly associated with not only quality of life and adherence to the treatment, but also survival. So it is as important a toxicity as any other physical toxicity is. And I think we have moved from that phase, and at least people now acknowledge for certain that this is an issue. And then we need to move on to how to measure this. And there are different ways of measuring this, but we need to get more scientific about it. And I do not have time to cover that all today. And after measuring it, how do we communicate about it? And after that, how do we involve all the major stakeholders to solve this problem? And to highlight the results from our survey that I showed earlier from WHO, for the same participants, we asked the risks of catastrophic expenditure from the patient in accessing those drugs that they thought were important. And you can see here, even for drugs like, gefapixant or, gemcitabine, trastuzumab, trastuzumab is especially important because this is the new drug in the context of LMICs. All other drugs are old drugs. And they responded saying that 68% of the patients would face catastrophic expenditure or catastrophic financial toxicity if they were offered trastuzumab. And even if for drugs like paclitaxel, 30% would face catastrophic financial toxicity for a drug like paclitaxel, compared to even a drug like pembrolizumab in high-income countries, where only 9% would face catastrophic financial toxicity to get pembrolizumab. So yes, modern cancer drugs are expensive, but the problem is the LMICs, they lack access and affordability even to old generic cancer drugs that are already in the WHO EML list. And that's why when we are fighting for access to cancer drug, we should not forget our objective. We should fight for meaningful cancer drugs, not just any cancer drug. And there is a difference, and that is what Cancer Groundshot is all about. Lack of access to new cancer drugs should not detract us from lack of access to meaningful cancer drugs and curative services like surgery or RT. Just to give an example, lack of access to trastuzumab for breast cancer or immunotherapy for melanoma is not the same as lack of access to neratinib for breast cancer or regorafenib for colon cancer. We should not be confusing these things. Okay, so access is not just to any cancer drugs, but meaningful cancer drugs. But how do we define that? How do we find what are the meaningful cancer drugs? Of course, there are several ways in which we can prioritize. We can look at the value of cancer drugs, magnitude of benefit versus the cost, whether the biomarkers are available or not, if that's a biomarker-based drug, the disease burden in the country, and the resources to manage toxicities. And the tools that are available for us right now are, we can start with WHO's essential medicine list and first make sure that all the drugs that are in the EML are actually being covered without financial toxicity. And we also have the ESMO magnitude of clinical benefit scale, which will help in prioritization of drugs. So let's move on to the issue of cost of cancer drugs, because this comes up quite often in our global oncology discussion. First, let's try to answer two questions that come often. First is, people think cancer drugs are cheaper in low and middle income countries. This comes up all the time. Cancer drugs are cheaper in India compared to US. Cancer drugs are cheaper in Africa. So are cancer drugs cheaper in LMICs? Is that true? And second, when we talk about cancer drugs being super expensive, the justification provided is that it's due to high R&D cost. And let's try to answer that question as well. Is the high cost of cancer drug due to R&D cost? So first, let's try to answer, are cancer drugs cheaper in LMICs? And there was this study published by Daniel Goldstein and colleagues, for which I wrote an editorial, in which they looked at the cancer drug prices in these 7 different countries in the world. And if you look like in terms of absolute numbers, it's true that cancer drugs are cheaper in LMICs compared to what they cost in high-income countries. If you look at the median cancer drug prices in this graph in India, South Africa, and even China, it is far less than what it is costing in USA. But that's the absolute number. If you control for the GDP of the country or the per capita income of the country, then it will show you exactly the opposite picture. It's far more expensive in India and China and South Africa than in USA, if you compare for the per capita income of the country. So yes, the absolute number might be less, but that would be 50% of someone's salary in India compared to being only 2% of someone's salary in USA. So yes, in absolute terms, cancer drugs cost less in low-income countries, but they are far more expensive in high-income countries if you think in terms of what percentage of people's salary they need to pay for affording these cancer drugs. They are cheap, but they are unaffordable in low and middle income countries. And moving on to the second question, is this expensive drug prices due to high R&D cost? And this was a fantastic study published by colleagues at WHO, in which they looked at these several cancer drugs, and they looked at R&D cost, and they looked at how much return on investment these drugs had achieved. And this is what they found. They found that per dollar invested for R&D, there was a return of almost $15. The range went from 3.3 to $55 for every $1 that was invested in R&D. This is excellent return on investment. This is something that Warren Buffett would be proud of. And within a median of 5 years' time, it was possible to fully recover the maximum possible risk-adjusted cost of R&D. So what this shows is that cancer drugs are expensive not because of R&D, it's simply because of profit. It's like $15 per dollar invested is what they are getting in return. So R&D cost does not explain the high cost of cancer drug prices. Profits explain. Okay, then these drugs are so expensive, and we know that in US we don't have health technology assessment, so whatever FDA has approved, the Medicare is going to pay for. But the other high-income countries in the world, they do health technology assessment. They look at different criteria before deciding whether or not to fund for the drug under the public funding schemes. And so we try to look at these countries in the world. This was a very recent paper that we published like 3 months ago in Lancet Oncology, in which we looked at the G7 countries in the world, plus Australia, New Zealand. And we looked at how do they make these decisions about whether or not to fund for certain drugs. And we found that all the countries, they look at the therapeutic impact. The drug has to be effective. And then most of the countries also look at cost effectiveness. And then there are other conditions. Some look at public participation and socioeconomic impact and quality of evidence, equity, and so on. But how does this translate into the actual funding decisions? That was very interesting to observe. This is what we found for these 8 countries that we studied. And this is a cohort of lowest value cancer drugs. We used the MCBSE score of 1, which represents the lousiest cancer drugs that are available. And we looked at what percentage of these drugs these countries are funding. And as you can see, New Zealand funds 0% of them. New Zealand does not fund any of those low value cancer drugs. Australia funds only, Australia and England, they fund only 17%, Canada 28%, and so on. And if you combine this graph with that graph of mortality versus expenditure that I showed earlier, you can see that, like in New Zealand, Australia, they have quite respectable place in that mortality graph. That means not spending on these low value cancer drugs does not lead to inferior outcomes in terms of cancer mortality. So there is enormous cost saving opportunity here by not spending or wasting money on these lowest value cancer drugs. And that money can in fact be used to fund for things that actually matter for patients. And as I mentioned, the biggest tragedy that I see is low-income countries in the world wasting the resources on some of these drugs that are considered lowest value even by high-income countries' standards. And whenever we are talking about this disparity or inequity in access to drugs globally, some people argue that clinical trials are the answer. Maybe low and middle income countries more and more should participate in clinical trials, and that will improve access to new cancer drugs. So are clinical trials the answer to inequities in access to new cancer drugs? Yes, they are, but not all clinical trials are created equal. One example, this is the trial of cemiplimab for patients with non-small cell lung cancer, first-line PD-L1 of at least 50%. For this same indication, pembrolizumab had already proven OS advantage in 2016 and was approved in 2016. But this cemiplimab trial, it ran from 2017 to 2020. And this was considered, and this had a control arm of chemotherapy. after pembrolizumab had already been proven to be superior to chemo. And therefore, this trial did not get approval to run in North America because nobody would want to get chemo. Everybody would get immunotherapy. So this trial ran entirely outside of North America and used that data to get the drug approved back in US, which is a very bad practice because these other countries that participated in this trial, they do not have continued access to this drug. They just participated in the trial because the trial could not be run in North America to get a drug approved in North America. And there are several ethical challenges to this, which we have discussed in this paper. But I'm not citing this as a unique example. This is getting more and more common. The control arm, the practice of using an inferior control arm to get the drug approved is getting more and more common. The first paper is in prostate cancer. The second is in lung cancer. This is happening all over in oncology. And some people argue that using that inferior control arm is okay because we ran it in low and middle income countries. But is that justified? And I think the answer is no, for two reasons. One, the Helsinki Declaration that everybody wants to cite, it actually says use the best standard of care, not the local standard of care. But the bigger problem I see is that all these low and middle income countries that are participating in these trials, they do not have continued access to that treatment after the trial is complete. So, if it's a multinational trial of 350 patients, let's say, only half of them would be randomized to the experimental arm anyway. And any one particular country would enroll at most like 5, 6 patients. So, that does not solve the problem of lack of access to all other hundreds and thousands of patients with that disease in that country. And in fact, in this fantastic paper in 2021, they looked at what percentage of these countries that participate in these trials will have access to these drugs after the drug is approved by the FDA. And this graph is quite enlightening. This shows Africa. And if you can see here, until 5 years after the drug was approved by the FDA, 0% of those drugs are available in Africa. And these are the trials in which African countries participated. Their patients participated in this trial, and the drug got approved by the FDA. But 5 years later, 0% of those drugs are available in Africa. So no, just doing this type of clinical trials in LMICs does not solve the problem of lack of access to the cancer drugs. What we need to be investing in meaningful clinical trials in LMICs. Just to give an example from COVID-19, remdesivir is like your moonshot example. Mortality benefit is marginal. It costs more than $3,000 for one course. It's not available globally. Versus dexamethasone trial for COVID-19. Mortality benefit is substantially cheap, affordable, and is available globally. So we need to focus on these dexamethasone type trials as opposed to remdesivir type trials. And there have been so many examples of good clinical trials that are being done in low and middle income countries addressing this type of need. But I want to give a special shout out to non-inferiority design trials. I think this is the way forward for running these trials in low and middle income countries, because in non-inferiority trials, the control arm does not get disadvantaged. If we take the same example of cemiplimab trial, instead of doing cemiplimab versus chemo superiority trial, we could have done cemiplimab versus pembro non-inferiority trial, so that the control arm patients would also get immunotherapy. And this is a good way to test de-escalation strategies. For example, is a lower dose enough? Can we give lower dose of abiraterone immunotherapy? Is a shorter duration enough? Is a lower frequency enough? All these type of trials, these type of questions can be answered using non-inferiority design trials. So in conclusion, cancer outcomes are dictated more by socioeconomic factors, unfortunately, than by biological factors. And these inequities can be multifactorial. And innovations that don't reach people are meaningless. A drug that patients cannot have access to, by definition, cannot save any lives. And ensuring implementation of high-value proven cancer treatments is equally, if not more important than discovery of newer interventions. And when we are fighting for equity in access to care, it is more important to prioritize interventions that make a real difference. There is no point in fighting for access to marginal cancer drugs or interventions that lead to overdiagnosis and overtreatment. And many lives are lost, not because they did not have access to newest technology or drugs, but because they did not receive proven interventions in time. And with this, I want to introduce you to a recent movement that we have started. It's called Common Sense Oncology. And we have written about this in this Lancet Oncology paper a couple of months ago. But this is a movement that we started this year, like in April. We had a meeting of 30 people from all over the world, including patients, patient advocates, medical oncologists, radiation oncologists, a group of people who are concerned that we might be losing focus in oncology and we are not probably improving outcomes that matter to our patients. So how we can get back to improving outcomes that matter. And I encourage you to check out our website. We have a website and we have just started, and we encourage you to submit a membership. It takes no money. You can just submit your name and be on our email list to get some updates. We have just started, as I mentioned, so we have not been able to do much, but we are planning to do a number of activities. This was the inaugural group of people, and we had also written a paper about this earlier last year, before we started this movement, about why we might need a movement like this. But yeah, thank you very much. I'm happy to receive any feedback or comments.
Great. Thank you so much. That was a tour de force, and I think many questions and topics that I think could have warranted an hour discussion in and of itself. So really appreciate that overview, and thanks for spending some time on the outcomes piece as well. I thought that was a great topic to loop into today. But lots of people on the chat, so I'll just sort of moderate here. If you wouldn't mind just raising your hand, and I can also moderate the chat if there's questions that come in. Give people a couple minutes. If not, I have plenty of questions. Right. All right. Anyone with a Shine
Hi.
Chang?
Yes.
Hi, yeah, great. Perfect.
Hi. Thank you so much. That was an excellent presentation. Although I did find it kind of disheartening because it's another whole universe of work that has to be done. And thank you for being there and doing that work. I was wondering, your last bullet on the last slide, I was wondering if you might have any thoughts on how to move the needle on earlier detection of cancer.